Excuse me, everyone. Thank you for your patience in holding. We now have your speakers in conference. Please be aware that each of your lines is in a listen-only mode. You may ask questions at any time using the chat box. I would now like to turn the conference over to Ms. Jen Braun. You may begin.
Thanks, Justin. Hello, everyone, and thank you for joining our monthly webinar series on integrating quality improvement methods to improve teamwork and patient safety. My name is Jen Braun, and I'm with the Health Research and Educational Trust. We're the research and educational arm of the American Hospital Association, and we manage the national implementation of TeamSTEPPS. Just a few rules of engagement before we begin. So you can access audio through two different ways. One is through your phone, which is in a listen-only mode. And if you dial in, and Sangeeta just sent the dial-in number and passcode there in the chat box as a reminder. If you dial in with your phone, you'll want to mute your computer speakers just so you don't get double sound. So if you don't listen through your phone, then you could listen through your computer speakers. So we'll use that chat box on the right-hand side of your screen to field any questions that you might have. So please feel free to chat them in throughout the presentation. If they're more logistical, we'll answer them in real time. But if they're content-based, we'll save them for the end to ask our speakers directly. If we don't get to all the questions answered or that you ask, we'll do our best to follow up with the speakers after and get those answers to you. I just wanted to flag some upcoming TeamSTEPPS events that we offer. We have this monthly webinar series that takes place on the second Wednesday of each month at noon Central Time. And we have registration available for next month's webinar, which is on TeamSTEPPS and the role of leaders in the NICU. In addition to our monthly webinars, we offer TeamSTEPPS Master Training courses, and registration is currently available for courses starting in January through April of 2016. Registration for courses in the summer will open at the end of next month. And then finally, our annual national conference will take place in June in Washington, D.C., which we're very excited about. Registration is filling up rather fast for that, so if you're interested in going, you can learn more on our website. And our website is listed right there. It's teamstepsportal.org. In addition, if you're not able to travel to one of our in-person master training courses, an online course is available, so you can register at that website listed there. But again, our website, teamstepsportal.org, contains a lot of information, including registration. As always, we are available by phone, or you can email us at that email there, arcteamsteps@aha.org, if you have any questions anytime. And then with that, I promise I'll keep this brief. I would like to officially welcome our presenters today from UCLA, where they serve as faculty. They're one of our 8 regional training centers that provides master training courses. Today you'll hear from Dr. Randolph Steadman, Bob Martin, and Ken Miller. Unfortunately, Yu Ming Wang is stuck in jury duty, but you have 3 very competent and great speakers today. And with that, I will turn it over to Dr. Steadman. Randy, the floor is yours.
Okay, thank you, Jen. These are the objectives for today's talk. We're going to compare 2 quality improvement models, those models being TeamSTEPPS and Lean, both of which are designed to improve patient safety. We're going to discuss how to reconcile the principles of these models. They are shockingly similar, and we want to point that out to you. We're going to demonstrate 3 Lean tools that can be incorporated into TeamSTEPPS courses and TeamSTEPPS implementation exercises. And we're going to give you examples of a project that was done here by Ken that utilizes these tools. This slide shows on the left-hand column a number of TeamSTEPPS tools that will be familiar to you. And in the right-hand column are Lean concepts that overlap the TeamSTEPPS tools. Now, these mapping of one concept to another doesn't work completely down the list, but indeed, many of the tools are very, very similar. And we're going to illustrate tools, though, that are different for you today so that they will add to the diversity of your TeamSTEPPS courses.
Okay.
Bob?
Okay, hi, this is Bob Martin. So, of course, we need to talk first about what is Lean. We talk about the principles first. Lean, it's really a management, oh, by the way, and when we talk to people and we ask them what their opinion about what Lean is, a lot of times people say reducing waste, improving efficiency, and while those are accurate, Lean is really a management system and a culture. And it's focused around designed as the way we work by adding value for our customers and eliminating waste, where every employee is empowered to solve problems and continuously improve their processes. So really, Lean is an empowerment and engagement methodology, and similar in many ways to TeamSTEPPS. And a lot of people, the next question is, well, who's doing this? As you can see on the upper left-hand side, we get our origins, well, it actually goes much further back than Toyota, but Toyota Production System is where we get our modern understanding of Lean. Companies like Porsche, GM, GE, but it's not just electronics and manufacturing. There's also aerospace companies. You've got Starbucks. You can go to monster.com and you'll see job applications forming for Starbucks Lean positions, 3M, Amazon. And on the bottom left-hand side, you see some of you are probably from these healthcare systems. UCLA Health really has started our journey just a few years ago, so we're very, very early on. We're trying to catch up to some of our friends across the country and other academic medical centers as well. And you even see some universities now and airlines that are trying to implement Lean. You can get certificates and learning from a lot of universities, but there's very few that are actually trying to implement it. So today, one of the main tools we're going to be talking about, even though Lean is about management fundamentals and engagement and things like that, it's also about methodology. And a lot of times when you take a Lean course, you'll focus on that. So we'll do a small focus on that, but keep those other principles in mind as well. So we are going to be simulating a problem-solving, what's called a PDCA, Plan, Do, Check, Act. It's basically using the scientific method for Lean, using a tool called an A3. At Toyota used a tool called the A3. It only means the size of a paper, 11 by 17. And they figured that it was a good size of paper to communicate anything which was a complex problem you needed to gain consensus with, managing a quality improvement project, to use if any time the root causes that you're trying to determine are really unknown at first. So it really requires data analysis and starting to look into things. So keep this model in mind, PDCA, as we're going through. We're actually going to be going through focusing primarily on steps 1 through 4 on the left, talking a little bit about step 5, and then look at check and act. But the way this works, PDCA, we're supposed to be spending a lot of time planning, right? So steps 1 through 4 is planning. And then step 5 is doing, right? So you plan before you do, and then you check what you did, and then you make adjustments, you act upon it. And that's what PDCA methodology is all about. But as you're implementing PDCA, I'm going to catch forward on my clicks here, but as you're implementing PDCA, as you're implementing the solutions, you also have mini PDCA activity which occurs in here. The UCLA, our culture right now, typically we'll do workshops, what we call rapid improvement events, and other things where we generate mini solutions and we kind of implement them all at once. But we're working towards a system that you implement one solution at a time using a more scientific, rigorous approach called mini PDCA. So you have the big PDCA, and then you have mini PDCA and the solutions. And the reason we're using this document, because the rest of the presentation, you're going to see us talking about the problem statement, some current state tools, formation of a goal, and root cause analysis. Ken?
Hi, this is Ken Miller. I am the Simulation Education Program Coordinator, and I also have a background in critical care and critical care transport. When I started TeamSTEPPS, I was actually the manager of critical care transport, and through just normal QA, we found that transport, our throughput process was very delayed for some reason. When we did the QA, we found that it took 55 minutes for a patient to get from our medical outpatient plaza to the ER or to a direct admit to the floor. It's on the same campus. So this was a huge problem that we found, and we needed to find we needed to solve this problem and find a solution. So when I first looked at this, I needed to come up with the actual problem. What is going on here? And I needed to look at the process. So in Lean, we have this tool called process mapping. And what it is a visual representative of steps in the process. And what it really shows is a good, clear understanding of what the process is. And it really helps us look at the value and the waste that is going on. There are several computer programs out there that really can help you with these process mapping. One is Visio, which is what we use here at UCLA. But each symbol represents a certain part of the process. Like all the circles usually are the start and the end. Rectangles are the task or activity. Arrows are the flow. The yield sign is either a question or a decision. So you want to look at your process to really get that clear understanding of what's going on. Now, when I did ours, this is what we would call a spaghetti map. And I really tried to honestly find out what was going on. It was a little difficult. So I did the best I could with the current process, but I found a lot of problems and a lot of waste and a lot of less things that I could improve the value on. But I really wanted to take this back to the group, to the whole transport group, to really show them, hey, this is how we're doing this right now, because everybody kind of did their own thing. And what I like about these current, say, process maps is it puts everybody on that shared mental vision, because it's like all of a sudden, oh, do you do that or do I do that? So a lot of value comes out of this, of just creating that map. So when we got together, and this is where TeamSTEPPS implementation tools come in. We got the change team going. We talked about how could we improve this. We offered several solutions, which I'll talk about in a little bit. But the bottom line is we came up with interjecting the S-bar into our dispatch system to help improve the time. Then we did a process map that really showed that lean process, that simplified process to get from point A to point B. And we actually did decrease our times by 22 minutes. So it was very successful. One of the tools that we also use in Lean is the time observation tool. And this actually measures what actually happens. So what I did is I did a simulation of a transport, and I documented the times that everything was done. And because I really wanted to give the staff a benefit of the doubt that this didn't take really 55 minutes, but actually this time observation tool validated that, which was helpful for the staff as well to see that this really was occurring. It helped streamline the process and identified waste. We identified a lot of things with multiple phone calls, duplication of information being transferred. You're able to describe each task in detail, look at the running line, and calculate the times and averages. So that really gave us a lot of value.
Hey, Jen, would you like us to answer the question that we put in there, or should we wait?
No, sure, you can go ahead and answer that about the PDCA and PDSA, sure.
Yeah. Deming brought PDCA to Japan, or PDSA, Plan Do Study Act, and in Japan, with this group of engineers, I can't remember the society name, they adopted it and adapted it for manufacturing, and they called it PDCA. And since then, they kind of evolved down different paths. And so the short answer is, yes, they are pretty much the same, but if you talk to some PDCA and PDSA zealots or advocates, they're going to tell you that they're probably totally different. But realistically, the principles and concepts are very, very similar. So if you see PDCA, you can generally swap it with PDSA. PDSA means Plan, Do, Study, Act. Go ahead, Randy.
So we're going to walk you through the second Lean tool, which is the time observation. The first one was the process map. So on the screen you see an example of a time observation that Ken did for his transport. And you see in the red box the work element. So you can see 9 different steps that are listed here.
From the request for the transport to getting ETAs, to giving report, to getting multiple calls from the CCTRN, which is Critical Care Transport RN, up to the time that they arrive at the patient bedside.
And that we've highlighted the clock time. So this is looking at the watch and noting the time that each of these 9 steps started. And the column next to it, time in step, illustrates that for the first step it took 5 minutes. And then there's a further column on the right in which notes can be added.
And so notes that we noticed during this observation was about our estimated time of arrival. There just wasn't one given, which can cause some anxiousness with the person requesting the transport. And it really identified a couple of issues that we weren't doing, like bedside report, for example. A lot of the nurses were getting report over the phone or through the EMR, and really Joint Commission does command that that report is giving at the bedside.
So this is an acronym, downtime, that is one of the Lean tools to identify waste. So the acronym stands for, as you see in the text box, defects, which would be errors, mistakes, overproduction, getting things ready too soon, excessive setup, waiting, which would be actual downtime. N is for not utilizing talent. T, transport, moving things around excessively. I, inventory, either too much, too little. M, motion, that would be moving people around. And E is extra processing, meaning unnecessary steps. So on the next slide, we'll see these illustrated. So again, this is downtime, the acronym, defects, overproduction, waiting, not utilizing talent, transport, inventory, motion, and extra processing. And on the next slide, we see that the downtime analysis has been expanded, and we see that the defects are added and have their own column. So here you see step number 2, which is waiting for the estimated time of arrival. That is a waiting step, so that's waste, and it would come under the waiting column. So you see 7 minutes added there in the waiting column. So you can see that following the clock time or the time in step column down to the very bottom, you see that it was a 55-minute process. But if you go to the rightmost column called task time, you see that the time in each step was really 18 minutes. So subtracting 18 from 55, 37 of the minutes were wasted time. So this is really drilling down and identifying the process.
And this gave then me, as the manager of transport, a chance to look at our process and how much time we could shave off that response time. And the national standard for transport is a on-scene time for non-911 calls is 30 minutes. So I identified 37 minutes that are wasted. So this was a big help because not only did we surpass our national standard goal, but we were able to cut down 22 minutes right away off the time. The process maps and time observations really helped us as a group define what our goals were. And our goal was to decrease that time from 55 to at least that national standard of 30 minutes within the first 6 months of implementation of this TeamSTEPPS project. The Lean process helped us with those maps, the time observations, and really gave us that definite, clear goal that we wanted to go to.
So understanding the current state, this is Bob, by the way, as you're going through that process, what you're trying to do, and this is step 4 if you were following along from that A3, is work towards trying to understand what the root causes are. The root cause analysis, this should be a familiar tool to most of you, hopefully. If we have adverse events in healthcare, hopefully that's not too familiar, or sentinel events, or if you have M&M or peer reviews at PPE, things like that. A lot of times, if we do have mistakes in healthcare, we try to investigate it as part of Joint Commission requirements. We use root cause analysis methodology, and we all have different systems to do that. But we also do the same thing in TeamSTEPPS, and we do the same thing in Lean as well. And I'll give you an example of why root cause is important. For this example right here, you have to think way back to the 1990s. And there was actually 2 memorials, the Lincoln and the Jefferson Memorial, even though it just says Jefferson on there, where the granite was increasing at a crumbling rate. And people were trying to understand why. There was a lot of theories. Is it acid rain? Is it traffic? And so if you start looking at actually what happened, it's pretty insightful. For example, and you might investigate acid rain, you might investigate everything else, but you're talking about, all this granite and everything else came from the same quarries. So when you look at all the rest of the different things, they discovered that these 2 memorials were actually being washed more frequently. And so you would ask yourself why, right? Root cause analysis is about using 5 whys. Well, maybe it needed to be cleaned more often. But why does it need to be cleaned more often? Well, because they had a lot of birds that were increasing waste. Now, this is a different type of waste than I was talking about last time, of course. So the idea is, should we eliminate the birds? Right? And usually, when I'm with a little group of people will laugh at that, but we don't have the opportunity here. But I'll give you a small story. Before I worked at UCLA, I worked at Boeing for 14 years, and my last assignment was helping out a supplier in Italy, Lean and TeamSTEPPS, implement a lean production system in a little town called Crotaglie. And this Italian guy would drive up every week in a little truck, and he'd have a falcon on his shoulder, and he would launch the falcon, and the falcon would take out the pigeons that were always in these very tall, gigantic aerospace airplane hangars. So they were trying to figure it out that way. But that's not just how it's done in Italy. In America, when I was a production manager on the 787 program, and this is back in the late 90s, they used to poison the birds, right? And we had these open bullpens. So we'd go out every morning, and we'd lay out our keyboards, and you can imagine what mess was all over our keyboards. I mean, we're washing them out in the bathroom. It was pretty disgusting, right? Because the birds would ingest the poison and go through them. But that wasn't the root cause of the problem. Why are the birds there? Well, they had a large number of spiders to eat. But why are the spiders there? Should we kill all the spiders, right? If we did that, the other insects would overrule the earth. But the spiders are there, of course, also for a food source. And they weren't actually eating midges. They were crawling up on the wall because these midges would swarm, and the ones that had these protein larvae egg sacs would hit the walls, and the spiders would crawl up and eat those, and then the birds would tell their friends, hey, we've got a lot of food over here, and suddenly we have, granite which is crumbling. But why was that happening? Because we still had all of these different memorials. Well, midges are attracted to lights, and at these 2 particular memorials, the lights were turned on about an hour before dusk. All of the other memorials, the lights were turned on 5 minutes before dusk. So you can imagine what the solution was. It didn't cost any money to turn the lights off 5 minutes before dusk. And believe it or not, we have these types of things happen in healthcare all the time. And the metaphor of root cause analysis is literally thinking about a tree, right? If a tree looks like it's sick or failing, you can't really tell by the branches. A lot of times the problems are in the roots, and you have to literally dig down. And as you're digging down, you're discovering the problems. So the current state analysis in box 2 points you out to where the root causes are. Root cause analysis is actually trying to find out why. So one of the tools that we use to do it, well, one of them I just demonstrated to you is called 5 whys, but another one is called fishbone diagrams. This is also called Ishikawa diagrams, and it's also called cause and effect diagrams. And it's a very, very, very simple tool to use. Ken is going to illustrate one in a moment. But all you do, just to let you know, is you write down a problem on the right-hand side or left-hand side of a document. You come up with several different categories, and in this case, you see communication, process, and environment, and then you start brainstorming or doing 5 whys to find out where all the different root causes are. Ken?
So I used this fishbone to try to come up with some solutions. Again, I really want to emphasize, because we are a nursing magnet facility, this was a group project of the whole transport team. This just wasn't me providing this and developing this. This was a group effort. So we were able to put this fishbone up, and we found that the problem was 55 minutes. So we broke it down into these groups of, is it a people problem, is it a communication problem, is it an equipment problem, or is it just a systems problem? So we all brainstormed, what about people did we identify were issues? One is the EMTs and the CCTRNs were doing different things. Communication, the dispatcher didn't receive any kind of report, which we looked at as a waste of talent. They could pass on something to the CCTRN to give them more of an idea of what's going on at the time. The CCTRN sat there and read the EMR for at least 10 minutes, investigating the whole history of the patient. So then we looked at our systems. Our elevators were slow. The equipment, a lot of times that the equipment was gone because there's a simultaneous transport, and equipment was really stored in 3 areas. So this really highlighted a lot of issues that we need to look at to help decrease this response time.
Should we get Marcy's comment? So, Marcy, reading your comment about 5 whys being messy and it can take root causes in different directions, absolutely true. If you do root cause analysis properly, it can take some time, and generally speaking, you will find several root causes. I saw a consulting firm once do a root cause analysis on why the Titanic sunk, and they found 17 isolated root causes. And the thing is that if you have to look under the surface, just like with an iceberg, it didn't hit the top of the iceberg, it hit like the side of an iceberg, which was underneath the water. And if you don't do the digging or drain the water to try to understand that, which is very messy, takes a lot of time, but think about our patients. We don't jump to solutions with our patients, right? We try to understand the root causes with our patients as well. So the idea is that we should also try to understand the root causes of our problems before we make decisions.
And you can do 10 whys. The 5 is just a general guideline. You can keep asking if the response can reply to a why, you can ask another why.
Yep. And it might tree out into 4 or 5 different branches, so on and so forth. It's a lot of work.
Like your 2-year-old, why? So this is our example of our A3. At the top, again, we put what our project name was, and that was improving patient throughput through decreasing response times in critical care transport. This is all the staff that was involved with it, the project team, and when we implemented it in 2014. We came up with our problem statement. Again, this is the Lean tools that we use to get to these boxes on the left. We came up with our current state. Well, our goal was our root cause analysis. And it's very important to show that root cause analysis to everybody, because they can look at it and they can even add stuff that you possibly might not even have known, other staff or other people walking by. It's very important to show that. Then the right side of the paper is more of the PDCA, the solutions, which we came up with really 2 basic solutions. One was to streamline the process. So we did the process map. The second thing was doing a TeamSTEPP intervention of applying SBAR to our dispatch. So what we did was we realized that the talent of the EMT wasn't being as utilized as it should be. So when they would request a transport, the EMT would get a simple SBAR report. And I put air quotes on that because it was just a transfer of clear communication. We needed to know why that patient needed to be transported. That was the issue. So the SBAR was designed to really look at why they needed to be transported, what problems we could be anticipating, equipment issues, and staffing issues. Those are the big 3 complications of transport, and that SBAR addressed all 3 of them. Then that SBAR was given to the transport nurse who looked at that SBAR. They got that information and decided what equipment they needed and what personnel they needed, and then they were dispatched to the bedside. Then the transport nurse showed up at the bedside, and even if there were delays once they get to the bedside, it's still the patient satisfaction, which was something we really had to consider as well. The patient satisfaction is better because at least they know they're there. It's when they're waiting for an hour for nobody to show up is really an issue with patient satisfaction. So we did our checks, we did monthly audits of our response times, we did audits of the SBAR intake, and then we did the initiation of discussing SBARs in our daily huddles. At UCLA, at the beginning of each shift, the nursing staff and we do a daily huddle to talk about things that are going on, and this was a great team step intervention again using these huddles because it did help us talk about the SBAR and what problems we were having. And then the action, we looked at this and we did change a couple of things on the information sheet that nurses felt they needed, but it really the ACT part is so important because if you don't, things just aren't stagnant. If you can find other things and other issues that that you can take care of, that's where the ACT comes in, and it just keeps getting better. We are continuing doing audits of the SBAR format. Our times now are still about the same. There is some improvement issues we're going to look at, and we're actually changing over to an electronic version with our Care Connect issue, which is going to really impact this whole project. So,
Someone has a question about the sample size.
The sample size of the audits, I want to say was 55 transports.
So we're actually able to do all?
During the
100%.
Yeah, it was 100%. So the outcome, by using these Lean tools and SBAR, we improved that response time from 55 to 22 minutes, which was even better than we thought. And actually, the first time we implemented this, the response time was 16 minutes. Now, with that said, you always have to watch for that Hawthorne effect because they knew that they were, we were implementing this, and you had so you had to take that in consideration. Now our response times are a little bit longer than 22 minutes, but they're definitely not 55 minutes, which is really was our goal. But again, this is a continual project. It's a continual improvement project, which our goal is just to keep getting better and better.
We answer some of the questions.
Well,
okay. So, in summary, we think that TeamSTEPPS and Lean tools are complementary. They supplement each other. We think that Lean tools can be implemented within TeamSTEPPS and vice versa. And just to review the Lean tools that we discussed, PDCA and the A3 form we illustrated. We showed a process map. We showed a time observation sheet. We illustrated the downtime analysis within the time observation sheet, and we showed a root cause analysis in a fishbone diagrammed format. And then we used the example of the transport team response times and transport times, illustrating these various tools. So we see a number of questions, and
start with I'm scrolling up to the PDCA tools. I'm not sure if everybody can see it. You may have it in screen mode. So there's a question from Norris about the PDCA tools usually include a check cycle. Ours definitely do. On the project management slide in which you describe the A3, there's no mention of a repeat check cycle. Yeah, it's definitely a continuous process for us. What we normally do is we integrate these into our daily, weekly, and monthly operating cycles. We'll use the PDCA to get us started, and then it goes into a project in that way. So yeah, we definitely use it. And by that point, we will typically keep a focus on all of the metrics and supporting metrics which are critical to make sure that the process is going to continuously maintain, sustain, and improve.
And this is directed to Mary Ann. Why is your target only 20% for completion of the SBAR form on intake? We specifically targeted a specific area. We do other transports, just not from the outpatient area. So this made up about 20% of our transports. And then we went to disseminating to other transports, because we picked up patients from other hospitals. We picked up patients from our sister hospital and transferred back and forth. So there's a lot of different, but we really wanted to focus on this medical plaza because that was where we were getting a majority of complaints. So that's why it was the 20%.
So Lisa, I'll take your question about what part of this is available to use. Of course, the presentation is available. We can make the tools available. These tools, everything that you see is pretty much non-proprietary. If you go to Toyota, GE, Boeing, it doesn't matter where you go. The tools are 90 or 95% the same, and they've been that way since the Industrial Revolution pretty much, except for the A3. So, yeah, they're available to use, but if you like the ones that you saw, we particularly like our A3 PDCA format because it directly links in the root cause analysis to test actual root causes in the solutions, but we can send that link out as well. So, and by the way, we didn't even talk about A4 methodology. A4 would be like a daily type PDCA, but the link that we send out will have both forms on there. Deborah's question?
So who tracks the action items? That you have to determine within your group, and to look at what, if they're doing it. Now, that wasn't my job as the coordinator. I was looking at, how are they doing this and was the forms being filled out correctly. You have to prioritize your action items and really see what you're going to get the full value out of. We knew that SBAR was going to give us the full value of decreasing that time, because the big issue when we did our fishbone was the communication. So that is what we did. Yeah, you can't have a lot of action items, but you have to prioritize and look at what's going to give you the most value.
Yeah, and we use a lot of times we'll use a two-axis, this is Bob, prioritization matrix. Some people call it the PIC method. You can probably Google that. But it's a great tool that you can use with the team to actually prioritize what you can do. You might want to phase out your action items. A lot of teams make a mistake by identifying 30 or 40 action items and just trying to do them. But really, you should probably focus on doing 5 or 10, at a time, or so on and so forth, or reduce the scope of your project so that you can get them all done. So,
so there's a question about what about using SBAR as an abbreviated A3. I don't quite understand that question.
I'll take this one. I don't know about, I guess there's a possibility you could use the SBAR. What I would do is encourage you to do some searching on A4 methodology. So the basic idea is if you know what the root causes are, like I think if you got a group of employees and you want to encourage them to submit ideas, you would probably not use A3s for very simple projects. You would use what's called A4 methodology. And it's very, very similar to SBAR. And I really hadn't made the connection until you asked the question. But A4 methodology would be the one. It's basically like 4 steps of the 7-step A3 methodology.
This is why we have the expert here for the lean process.
Yeah, correct.
How long did it take to complete the process map? That's a great question. After we did the time observation, I went back and kind of sketched it out myself, but then we took it to the staff meeting and had the staff look at it and continue that process map, because everybody was doing something a little bit different. When we did the time observation, that nurse did something different than another nurse that was on the next shift. So it's so important, again, to get everybody's input on this, because it's going to identify more problems with that process map. So it took, I'd say, at least minimally of 4 times meeting with everybody and all the staff that are involved, because we had separate EMT meetings, we had separate nursing meetings, and we also posted the process map up in the patient, our wait room, where we would wait for the calls, so everybody could also add their process. And then we would put up Also think about improvements. What could we make here? We use little Post-it notes, and people would write on there during that process what either they did or what they felt would be different, and that was very helpful. So my advice is this: make sure it's thorough, and that everybody has a chance to put into it, and it's just not kind of a one-time shot. So it can take several weeks to really get a solid process map.
So Nell, I'll take your question about triaging projects. I'll let you know how we do it at UCLA Health. This is Bob again. I work in a group called Performance Excellence, and we spend probably a little more than a half to two-thirds of our time getting direction from our C-suite on health, and we're like a SWAT team. We go out and we try to resolve health system level problems. But what we also did was we formed a collaboration between nursing, medicine, and operations through an institute called the Healthcare Improvement Institute, and through that we developed a Lean Academy. And what we do is we have a course where right now it's just internal employees, but they go through a certification program so that managers and directors and so on and so forth can send people to our class. We will train them, and then as they're doing their projects, then what we do is we coach them and mentor them for at least an hour a week. So that way, because Lean shouldn't be focused just on improving the bottom line or just the top level problems. Really, it should be an all-out whole cultural change. So really, my ideal for me is that you just let everybody do the projects as they want. Go ahead, Ken.
In the case of nursing, we allow the bedside nurse to go to the Lean Academy and learn these things. So, because they're the ones who identify the problems. They'll come up to the management and administration and say, hey, this is going on. And they're able to apply this Lean methodology, which really kind of validates their issues, too. And it gives them some good tools to use to help solve these patient care problems and issues.
This is Randy Steadman again. The hospital has a committee, the Performance Improvement Committee, that also triages projects. So to get the attending physician buy-in, we definitely try to avoid too many projects going on at once. So that would also look at more institution-wide projects. So there's a number of ways we might do that. I'll also take the question about Care Connect. Sorry, that's our UCLA term for our electronic medical record system.
Yep, and that's based on Epic.
And Dan, thank you for pointing out that lean.org has templates. And Bob, do you want to take Laura's question?
Laura, how long do you keep a focus? At what point can you stop, monitor results, and stay good? I'll tell you a story. When I was a production manager many years ago, and we did this simple improvement production system on trying to align these brackets on overhead cabinetry in an airplane. And after we implemented the project, about 6 months later, one of the Shingijutsu consultants that we learned Lean from came and said, hey, let's go ahead and do that same project again. And I looked at him like he was nuts. I said, what are you talking about? We already improved it. And this is when I was still learning, of course, in the mid-'90s. And at that point, I didn't realize that this was really about continuous improvement, and you never really stop monitoring. When you stop monitoring, that's when you're done, right? And you're not going to improve anymore. So you actually have to completely change the way your culture works, and it's extremely difficult, if you're not there already, to try to get there. But remember, this is culture change, and it can take 5 years, 10 years. Toyota said that they've been working on this for 50 years, and they still haven't perfected it. You want to scroll down?
Yeah. So decide this goes 100% of the subset of transports that you were. No, this. Marianne, in response to your question, the goal was 100% of the subset of transports that we were having trouble. We wanted to improve those times, so that was our 100%. So in the problem statement, what we should have done is really said in the medical plaza transports to make it a little bit more specific. So, but that's our 100%. So now I'll go back and look at my project and reevaluate it. But I agree with Bob 100%. These are never over, and we can always improve and keep improving and keep improving.
Yep.
Because we want those outcomes to affect our patients, and that's the overall goal of using both these processes. So
yeah, we spend a lot of time, and people tend to spend a lot of time on the P for planning, and then the doing, and they spend very little time on the checking and acting, right? So a lot of people are good at PD but not CA, and and including us, right? When we do that a lot here, so we're still working on that as well. But you definitely have to institutionalize it over time.
Cynthia's question about collecting the process times data, I think that's really the time observation that does that. And the time observation can be done either by an outside observer who is devoted strictly to that task, and that can take a day or two or even a week. It can also be done by the employees themselves, but then their recording of the times will interfere with the accuracy. So an outside observer is probably the best way to do that. But then the project lead, which in this case for the transport team example that we gave was Ken, needs to assemble that data into the process map, which, as Ken illustrated, started out as a spaghetti map and then was streamlined into a much smoother process.
Good. Thank you, Kathy. So Chris Anderson, you asked again about the tool that we use for prioritizing either problems or solutions. The original tool is called the PICK method, P-I-C-K, and it stood for, it's a 2X system to evaluate two different criteria for anything to see if something is possible to implement, or I can't remember what C is. Consider. That's what it was, like consider for later. Or the last one, K, was kill, right? But we can't use kill in healthcare, right? The manufacturing term is PICK. So we call it a prioritization matrix. But if you type in prioritization matrix, it might be difficult to find. That's why I'm letting you know, look up PICK method so that you can find it online. We also don't want to kill people's ideas. You want to, so as far as an example of action items, do we want to look back? So Minty, I can't read it.
So if you look in the upper right box of solutions, here, Minty, you'll see the tested solution was complete a revised process map and do mock simulations to examine the process, see whether it's feasible. And then the second row is have equipment available in one area to avoid having 3 equipment storage sites. So those would be 2 examples of action items.
But I think the message, though, that we want to convey is that when you're doing solutions, what you want to make sure you do is tie in all of the root causes that you developed in step 4, the ones that you can actually, after you've done prioritization or whatever you did, that's when you come up with a solution to it. So a lot of people don't directly tie in the root causes to solutions. So I think that's probably the more pertinent and powerful message. Yeah. Go ahead. Deborah. Yeah, that's another TeamSTEPPS.
Example, implement a debriefing tool following an episode of behavior. Yeah, that's a great TeamSTEPPS intervention. And again, using this model we just gave you, you'll be able to change that culture in your units of everybody doing that debriefing. One of the problems we found with debriefing after events like this is the staff will say they're too busy or they don't have time. Just a tidbit, just really try to swoon them over and really keep that debriefing short. So once they live that debriefing, they're going to be able to see, okay, yeah, this doesn't take long, and really emphasize the value of what they get out of it, and then hopefully vicariously everybody else will see that and you'll be able to change your culture. Dan, from standpoint, how is the staff involved in tracking current improvements? Yeah, unfortunately, I left the unit. I took another position, and so the follow-up wasn't as robust as I would like. It's hard to leave a project when, especially, you get good results, and that is definitely something that you do have to figure out of how much the staff are. The staff was involved 100%. The EMTs were responsible for involving, getting the SBAR, documenting the times, and then we would review this in staff meetings and then be able to get everybody's suggestions on what could be improved with it or what we can do differently.
But I think Ken has a powerful message there. Like, for example, when I talk about performance excellence or anybody else doing a project at UCLA Health, we don't go in and just do a project. We involve people. There is research. You can do research on participation and decision making with quality improvement. If you do not, and research directly supports this, if you do not involve employees throughout the process, especially when it comes to participating in decision making, you will reduce morale. You will reduce their role breadth, self-efficacy, or engagement or empowerment. And you can actually increase anxiety as well. So that's something you have to be very, very careful about when you're doing quality improvement. A lot of quality improvement and lean improvements actually result in reduced outcomes if you don't involve the employees. Where are we at?
And I think there was another powerful message, too, and that is that sustainment is many times the toughest piece. And as Ken illustrated when he transferred jobs, there was some drift in the improved outcomes. They haven't drifted back to where they were, but it takes an ongoing commitment, and that relates to a question that Bob addressed earlier, and that is, when do you stop monitoring when the results are good? And Bob's answer was, you never stop, because there will be attrition of personnel or culture changes that occur over time, so that's why the monitoring needs to continue, albeit maybe not at the original frequency.
Sure. Yeah, but the more you can embed these things into your management systems, the more successful you'll be. And does it look like we don't have any more questions? Thank
Correct.
You for,
this is Jen. I think you guys got everything. I want to be sure that we get to your contact information there, if that's okay. So I think since there aren't any more questions, thank you for covering all those questions, you guys. What we'll do is we'll make sure that we email everyone some of the tools that Bob and you guys mentioned. We'll email that to everyone who is registered. We will also email everyone once the recording has been posted. We recorded this, so we will post this on our website. So I think with that, since there aren't any questions left, we won't keep you all here any longer. So I want to really extend my thanks to the UCLA faculty. They're really great to work with, and I think the work that they're doing is really integral to the times in healthcare right now, and I think this is really useful. And again, their presentation is available to be downloaded there in the box above, or it's on our website. It's www.teamstepsportal.org. So thank you, everyone, and have a great rest of your day.
Thank you.
Thanks for joining us.
Thanks.
And
bye.
Happy holidays, everybody.